So hello and welcome. Thanks for taking time out of your day to join me on today's talk. Normally I'm interviewing someone, so if I start to talk in third person, make sure you send me over a little red flag. But I am Bridget Wallace. I am co-founder and clinical director for 360 Neurohealth. I am a vestibular physical therapist. I have a clinic here in Austin, Texas, and have been seeing patients with dizziness and balance disorders for the last 25 years. And also wanted to say not only thanks for taking the time out, but several of you sent in some really great questions that I can't wait to get to. And there's been a couple of responses on our Instagram page where you're sharing your opinion. And so that's very much appreciated. And I encourage you to continue to ask questions. I also have Jessie on the call, who is a co-founder of 360 Neurohealth, and she's going to help me stay on track with your questions as well. I do want today's talk to happen pretty organically. I don't have a PowerPoint presentation. Certainly it's easier to do it in this format when I'm interviewing someone else. So I made some notes so that I make sure I stay on track. Some of you may have seen the social media promotion on this where there's kind of 5 takeaways, and we can loop back around that at the end. I think we're going to have more than five takeaways just by reading the questions that I've received. So, one of the things I want to talk about today is, just defining optokinetic stimulation, talking about the different types of dizziness of when we use optokinetic stimulation. How do we do that in the care plan? There's going to be some open, questions and recommendations around that. And, how we associate it with different disease processes. And I think really that one of the take homes is just the need for us to learn more about this. And I'm going to wrap up today just by inviting you, encouraging you in some ways that maybe that we could do that together. So optokinetic stimulation is essentially what happens when we're tracking an object in a large visual field, where if we think about the vestibular ocular reflex, I'll have my eyes on a target and I'm rotating my head around that target. Whereas I may be, tracking something and it's a large visual field. So optokinetic stimulation, a little bit different than VOR, however closely related. So when we think about dizziness and this more and more talk about optokinetic stimulation, we see a growing number of articles written about it. There's so much we don't know, but I thought I'll talk a little bit about dizziness, and this is going to wrap around to a really great question that someone sent in. Is, there's movement related dizziness, which we commonly relate to the VOR. Dr. Marisa Pavlou published a great article, I think it was in 2010, in the neurology journal of the PT neurology journal, about optokinetic stimulation in vestibular rehab. And then she defined it as visual vertigo. So that's how you may recognize it. In her later publications, it's visually induced dizziness. And more recently, I've really seen the acronym VID, or visually induced dizziness, used in reference to 3PD. So I thought what I would do is I'm just going to read the definition as related to 3PD as she originally defined visually induced dizziness, or VID. but it's dizziness triggered by complex, distorted, large field, or moving visual stimulation. Again, it's commonly associated with 3PD, commonly associated with those folks who have persisting symptoms of dizziness following concussion. And then you may also have come across the acronym visually induced motion sensitivity. And I'll read that definition to you as well. It is a consequence of exposure to perceived motion in dynamic environments. So this would be more like virtual reality or being in a movie theater. And then of course, these are both different than motion sickness. So the other one, no recognized acronym for, but would be this persistent sensation of self-motion. And that may be rocking, bobbing, more commonly with the diagnosis of MdDS. Particularly, 3PD and MdDS can present very similar, whereas one of the key characteristics of MdDS is my symptoms are worse when I'm still. And with MdDS, we commonly associate that with after being on a boat, or a combination of prolonged air travel, car travel. It's after this kind of being in this passive motion, which actually relates to the protocols that I'm going to talk about that have been researched. For today, I think I'll focus more on visually induced dizziness, as well as this kind of perceived sensation of self-motion. And again, I'll continue to monitor your questions, because even though I have some kind of areas that I'd like to talk about, really what I want to save time for is addressing the questions that have been sent in, as well as letting this webinar kind of organically grow by your own questions. So, yes, there will be a recording to watch this later. And then we've got a question on how is oscillopsia different from other visual dizziness? And I think it's great to kind of get some of these questions about definitions out of the way. So oscillopsia is a term that we hear when objects oscillate or jump or move. And oscillopsia is commonly related to vestibular dysfunction, particularly in those with particularly in the early phases of significant unilateral loss, but more commonly associated with bilateral loss, so that if I turn my head to look at a target, it oscillates. Or with bilateral vestibular loss, it can happen just in walking, just with the force of the foot hitting the ground, things oscillate. So they may have a visual sensitivity due to the oscillopsia, things kind of moving and slowly oscillating with either a more rapid head movement or a force like your foot hitting the ground in walking. It doesn't even have to be a large visual field. So hopefully that clears it up a little bit about the term oscillopsia. So if we look at dizziness and we think of movement-related dizziness, when I move my head, particularly with brief head movements, that gives us a clue that the vestibular system is affected. We want to be testing the VOR. Visually induced dizziness, typically described when I go to the grocery store, even just the computer, busy patterns, not necessarily related to, what happens when I'm in the car or on a plane. And then again, like I mentioned, is the dizziness described as when I'm still, I have this rocking, bobbing sensation. And sometimes they may say, hey, I just feel like I'm going to fall through the floor. And so those give you different clues, not only about different systems that may be involved, but what your interventions may be. So, just like when we're questioning someone, we're creating a working diagnosis. when we're listening to their symptoms, we're also creating kind of this working idea of interventions. So if I hear with brief rapid head movements, I'm thinking VOR. If I'm hearing more symptoms associated with when I'm still, then it's worse. I mean, I'm better when I'm actually moving. Then I'm thinking, that's a little bit more related to what we would think for MdDS. Either it was triggered by a boat ride, or it can be a non-specific event that triggered these symptoms. We see this with hormonal changes. Sometimes it is a little bit more difficult to identify that a specific event. And when that happens, it's oftentimes we find that's a little bit harder to treat when it's not associated with something specifically. And certainly with 3PD, there's been more research using, particularly with Dr. Pavlu's work on optokinetic stimulation in 3PD. And the difference, which I'll talk about, is with the work by Dr. Day and his colleagues showed the use of optokinetic stimulation with a passive head movement. And I'll be reviewing some of the characteristics or some of the features of that particular protocol and how we may use optokinetic stripes differently based on that. I think we all agree the importance of making an accurate diagnosis. It helps us customize the care plan. Are we going to refer? Are we going to recommend more testing? How are we going to treat this patient? It allows us to have more confidence in our care plan when we know the underlying cause or causes of someone's symptoms. But we don't want that diagnosis to define our patients. I call it kind of leaving the diagnosis at the door. So we don't want the patient to define themselves as having a syndrome like Maladé-Bartman syndrome or post-concussion syndrome. 3PD is a syndrome, and that's not how we want the patient to define themselves. We want to define themselves through their recovery. What are we going to do for you? How can we help you? What resources can we find for you? And share with them what we know, and not be afraid to talk to them about what we don't know. And I think it's a pretty easy conversation to have because we have some research. Yes, it's limited. We know there's the need for more, but sharing the research and then saying, what we know is we have to customize this. So it really depends on your feedback, your involvement, your participation in your care plan so that we can customize it. And I recently put together a protocol for MdDS for our clinic, just not to tell people anyone what to do, the clinicians what to do, but it is, let's try this approach. It's based on the articles out there on this feeling of persistent self-motion. And we had to modify it because the research out there is 5 days in a row. It may start with one set, but then it goes up some people do 3 sets to 8 sets, and there's a 30-minute rest period between each set. So you're thinking of, as a clinician, if someone's coming into your clinic, A, can they come 5 days in a row? B, if you're having someone do up to even 4 sets of something, even though that may only be 4 minutes of exposure to optokinetic stimulation, it's recommended, the research is done with a 30-minute rest period between each set. So you have to start calculating how long someone may be at your clinic, and that's not practical for us. So it was looking at the research, what is this commonality in these different protocols, and how can we make this applicable not just in our clinic? So we're fortunate to have the computerized dynamic posturography that has the optokinetic stripes in it. We also have, actually it's Vertex BVT, visual trainer that has optokinetic stripes. And then we have made some optokinetic videos that patients can use at home that are very standardized. And so how do we translate that into a home program? I think one of the biggest takeaways we're going to have at the end of this day is the need for more research. And, it was apparent in the questions that we received. So many of you are asking, how do I dose this? What's the frequency? What's the duration? And I will review some of those guidelines, but I will not have the answer for you. But I think as we work together and share and collaborate as clinicians, that we'll learn from each other. So like we're going to learn, we just started implementing this protocol. And I mean, I've only given it to 4 patients now, and I'm modifying it every single day based on either a questionnaire that I've given them or what they're emailing me back, and I can talk about, I will be talking about some of those things. And, everyone's having different responses. So we're going to learn from this, what works, what doesn't work. But the more we can work together, I think the more we're going to be able to customize our treatments and more confidently say, what is the dosing? We actually, as much as the VOR has been studied, we still don't even know what is the optimal frequency and sets of VOR exercises. And then, we've got a comment here. So back in Europe, patients do not use the fixation point while stimulating. What is your opinion? And, I have a question back to you. So I think the question, I'm assuming when you say stimulating, it's also with an optokinetic reflex. We do both. So we use videos with no centralization, no central focal point. We use it with a moving target. We move it with the center target. I think, the most use of the central target for us is when the patient simply does not tolerate it. Because as you know, and I think it's why you're asking the question, is our patients are too centrally focused. So if we're giving them that central point, they're really maybe ignoring the background, which is part of the issue with their symptoms as far as we understand. But there are patients that simply will not start any other way. So, I guess to more precisely answer your question, yes, we use it. B, it's not our first choice. In fact, it's our last choice. Unless we know right away that someone has a notable amount of anxiety, we'll say, we're going to start you here. And then we start moving it, the target. And then we have some videos where we have a number or a simple math problem in the target where now they're having to do a cognitive task, and then we take it away. And I'm certainly interested to hear about other things that you're doing, because what we've changed a bit is that we start in a more supported position or seated position, because, a little bit less about patients that have been diagnosed with MdDS, but with 3PD, is imaging showing this sensory mismatch, a poor sensory reweighting, and a poor use of ankle strategies and somatosensory cues. So whereas I have historically been a little prone to put someone on a piece of foam or an unstable surface, now I'm saying, you know what, we need to tap into your somatosensory system, because the research is suggesting that patients are not using somatosensory appropriately. And so it's like, well, let's have you using what you have. And so we do a lot more in seated, a lot more in ankle strategies, focusing on the somatosensory system while we stimulate. So I'm not sure what approach, that you may take, but that's definitely been an evolution of how we've changed our approach. And please just keep your questions coming. Again, I'd like this to to occur very naturally. I do have quite a few questions sent in. So what I'll do maybe is I'll start to address these, and then I'll keep checking in with questions. And when I say questions, maybe it's a comment that you want to share, like you just shared what you're doing. And I think there'll be a lot of takeaways from learning what other people are doing. So here's a question. How do I identify an optokinetic dysfunction? And there's several questions here, so I'm going to try to break this in this one. How do I know I'm giving a proper dosage? And if my patient plateaus, how do I modify the exercise? So these are all great questions. And so let's just break this down. So in the clinic, we don't identify someone as having an optokinetic dysfunction. The way we would word that is this patient has dizziness or visually induced dizziness when exposed to optokinetic stimulation, meaning when exposed to trying to track an object in a large visual field. They have visually induced dizziness when looking at the computer, being at the grocery store. And so we do identify that there is a certain symptoms associated with optokinetic stimulation, but we don't define it as an optokinetic dysfunction. Now, on the other side of that, we do provide vestibular diagnostics in our clinic. So we do OPK testing. And OPK testing is with a VNG, or video nystagmography. So they are following a stripe out, which is tracking, and then they're coming back and picking up the next stripe, which is saccades or saccades. And so that's a combination, not to be confused with nystagmus. So following a target, coming back and picking up the next one, following it out, and we're measuring that. Typically when we see abnormalities and we rely on that data in optokinetic testing with a VNG, we go back and compare that to how they did in smooth pursuit, and abnormalities in both of those are a stronger indication that there's a central dysfunction. The majority of our patients don't have central nervous system pathologies, but they have symptom provocation with the optokinetic stimulation test. And we're looking for that. So, okay, well, what if I don't have a VNG? You know, a quick optokinetic stimulation screen is doing what we historically would call the VOR cancellation or the VOR suppression test. In the concussion world, and you see this called the motion sensitivity test, or we use motion sensitivity test more frequently in our patients with dizziness. So that's, either you passively move the patient, so they're tracking a target during rotation, and you're looking at how smoothly they stay on the target. With cerebellar dysfunction, they'll have a corrective saccades. That is a big central sign. Most of your patients will not have an abnormal neurological finding, but they have symptom provocation. And so that indicates that they have visually induced dizziness. They have dizziness when exposed to optokinetic stimulation. So we do test it in our clinic with both VNG and then functionally by doing what we call the visual motion sensitivity test, or what you may know is the VOR cancellation test. Okay, and so next question there, same person, was how do I know I'm giving That is a really important question. The literature varies. If you look at the research articles on MdDS, it ranges anywhere from 3-minute exposure to 5-minute exposure to optokinetic stimulation. Now, you may have a patient that can't tolerate that much at once. When I've heard Dr. Marissa Pavlou talk, she has referenced that she may start with 10 seconds of stimulation. So, we do have videos that are 10 seconds of an optokinetic stimulation, and then 3 sets of box breathing, and then 10 seconds of stimulation, and then a set of box breathing. So you will have to customize it at first. So start small and gradually progress the dosing. I think what we do know from the research is, in the past, I historically relied more on go to YouTube videos or go to the store. And so now we provide very clear, distinct instructions. We don't say go to YouTube videos. We provide them videos. We tell them when, we advise when to do them and starting in a seated position. And we do say, we're interested in your symptoms, but what we're most interested in is your recovery. So we expect patients to have some symptoms. If they don't have symptoms to the stimulus, or if they don't have excessive sway when we're having them do a balance exercise, we don't think they need it because there's no impact or impairment associated with it. So we want to say, yes, we think you will be moving into a little bit of uncomfortableness here, and we want you to let us know about it. But what we are really interested in is your recovery. How long did it last? Because if you were able to recover quickly, then we're going to encourage them to go back into the stimulation. When they get to a point that they can't, their recovery is taking too long, then we're like, stop and let's get out of the provoking activity. And you're going to, what is that recovery time? And, I have colleagues that use the 3-minute rule. In the clinic, we use the 15-minute rule. 5-minute rule, but for home programs, we use the 15 or 20-minute, meaning we know they're exposed to more things at home versus controlled in the clinic. So we think there may be a little bit longer recovery time. So recovery is key. And also, again, just letting them know we will be putting you into some discomfort. But the more precise and clear, concise we can be in recommending exposure to optokinetic stimulation, I think the better outcomes and the better adherence we're going to see with our patients as part of their home program. So if my patient plateaus, how do I modify it? That's going to vary to the patient. That's really customization. So for one patient, it may be going from doing this from seated to standing. From another patient, it may be from standing to being on a piece of foam, because ultimately part of what we're doing here is habituation, where there may be some smaller internal adaptation occurring, but we're trying to increase their endurance to the stimulus. So that is really where I see habituation come in, is particularly with VOR. I mean, we know there's a high level of adaptation with VOR exercises, but can they tolerate the stimulus over and over and over? So we may be using some habituation to increase their endurance to performing that activity. So just customize it to your patient. We like to start on a firm surface. Again, you may find in the future that someone published research and found that it's better if you start on an unstable surface. And the reason I say that is because historically, I have almost always provided VOR exercises first and considered exposure to optokinetic stimulation as a progression. Whereas Dr. Pavlou published where they had a group of optokinetic stimulation initially. They kind of had a controlled sham group, and then a group that was doing just customized vestibular rehab. And what they found is the group that was getting optokinetic stimulation right away had the fastest improvements. Now, in the end, those groups showed the same outcomes. But I have said, if I can have a patient that is having faster outcomes, the likelihood that I can get them on board long term is greater. Now, have I evolved that I start everyone with optokinetic stimulation and VOR? No. I practice it, but I've just been giving VOR first for so long and then adding optokinetic stimulation that it's a little bit of a transition for me, but I definitely am giving optokinetic stimulation much earlier. And, I think as more and more people collect data and do the research, we're going to look back and it's just like a concussion. 20 years ago, I was given a lecture on grading a concussion, which is, those are in the trash can now. So we're definitely, have to take into consideration that something I say now, I may not do in the future. I do see a question come up. How quickly do you see a functional improvement? For example, I can now manage to be in the grocery store for longer. Great question. Grocery stores can be challenging. It's so much different stimulation, noise stimulation, unpredictable stimulation, like people moving around you. On the balance perspective, I think balance is the easy part for people to begin to, as long as they don't have peripheral neuropathy, can begin to say, I'm really beginning to see a functional improvement. One consideration I have about this is when we think about functional improvements is this has a little bit to do with the model of called successive approximation. So let's just say we have someone out here that wants to be able to go to the grocery store and run other errands without symptoms. So it's like for someone that may be like running a marathon. And then we're starting here where we don't do anything. We're in bed. So maybe for the patient with dizziness, we just can't go out of the house. For the patient who's, and I'm completely stealing this analogy from neuropsychologist Dr. Pardini, if, in working with a high-end athlete who can't do a 2-hour workout and feels a little bit depressed about it, and so just stays in bed. Well, that staying in bed is not getting closer to the end goal. So teaching and talking to our patients about, okay, you want to be able to go to the grocery store without symptoms. What if we take baby steps? What's a store that you can think of that's not as busy as your grocery store that you could go in that's a little bit more predictable for, instead of 45 minutes to do your shopping on a busier day, what if you could go for 10 minutes? And so the functional improvements, I think, have to be small. We have to take baby steps and let people know there may be some level of discomfort, but you're not harming anything. You may be feeling bad. So instead of thinking, I can now go to the grocery store, can you go to the grocery store for 5 minutes? That is a functional improvement. Now, those small baby steps, you can see. It may not be overnight, but I would say within the first definitely the first 3 weeks, is think of activities that are similar to the end goal in smaller durations and kind of baby steps. Okay, here's another question. Another awesome question. A patient will complain of persistent. So here's what I'll say. A patient will report persistent dizziness during standing and walking. Also symptoms when standing in the shower with the head down, as well as getting up from sitting. No symptoms while lying down. History of BPPV, but negative at this visit. Orthostatic hypotension had been ruled out, which is great to put in, because when I hear dizziness from sitting to standing, I think, has orthostatic hypotension been ruled out? Cleared by cardiologists, neurologists. It's not lightheadedness. So that's great to know too, because lightheadedness and orthostatic or vascular tend to go together. Is this still vestibular? What are the possible treatments? What's your advice, recommendation? That's good information. I think my first recommendation, because I'm just reading a few sentences here, and you likely know or do know this patient much better than I do. So just kind of instinctively, it would be to better understand their dizziness. So the first thing I would say, so you've already done it. It's not lightheadedness. The other thing would be, can you describe your dizziness from sit to stand without using the word dizziness? And so are they going to say rocking? Are they going to say swaying? Are they going to say leaning? Where that to me is this more persistent sensation of self-motion, even though they're still. Now, if the patient has any decreased sensation in their feet from peripheral neuropathy, when they stand, their sway has to be bigger than someone with intact sensation. Because when I'm fortunate enough to have normal sensation. So when I stand, I'm swaying, but you can't see it. It's so small, I can pick it up that you don't see me swaying. When someone has a sensory loss, when they stand, they have to sway to get more sway higher up the chain to pick it up. So, I would have a question, is there any neuropathy? If not, and let's just say there's rocking and bobbing or being pulled, then I would consider that a persistent sensation of self-motion. And, when we hear that, I'm already thinking optokinetic stimulation, and then I have to think about what direction are those straps going to be. Well, then I have to ask them a question, what directions are you being pulled? If you're being pulled to the left, then we want the stripes to go left to right. No, I feel like I'm falling forward. Well, then we want the stripes to go bottom to up to top. So we utilize that information. And, if you've read the research specifically on MdDS, it's even using the Ficuta's 50-step march test to determine which way you want the stripes to go when the stripes are vertical. So when the stripes are up and down, going side to side, you actually use the Ficuta's 50-step march test to determine if what direction those stripes are moving. So I think, I'm a little vestibular biased. I would think, though, overall, when I think sit to stand, yes, that's a movement against gravity. Vestibular system is sending information. But once they're still, I'm not thinking overly vestibular, because the vestibular system is most activated with a head rotation or a movement against gravity. When we think about how it's, the actual inner ear is activated. So walking, I definitely think inner ear, but we're also using all of our sensory systems. Well, we're using all of our sensory systems all the time, some just less than others. In walking, is it coming from the visual system? Is it coming from the vestibular? So the visual system, remember, large visual field. So you have a patient up and walking and looking around, or just in walking, looking at a target. They're not moving their head after the first few steps and they're focusing on a target, then I would think that's a little bit more from the visual system. But if it's with a rapid head movement, now that makes me think vestibular. So often we see a combination of both of these. It's not just one system in isolation. So let's just say we think there's a vestibular and a visual, an optokinetic stimulation. So we think about, how can we do both of those? We do the VOR through either VOR times 1 or VOR times 2, walking with rapid head movements. There's a variety of ways we can do visual stimulation. And then in seated, we want to optimize use of the somatosensory system. So, we're always looking at those sensory systems and how the person is utilizing, or what we call sensory reweighting. And then I have a question here, which it might be easier for me just to type this in. So I am going to type in Ficuta's 50-step march test. So the literature recommends utilizing that test to determine the direction of the vertical stripe patterns. How does reliance on meclizine for 10 plus years affect prognosis in vestibular rehab therapy? for triple PD or 3PD? You know, just that's another great question. What do we know? We know that meclizine is a vestibular suppressant. And as vestibular clinicians, we don't like the use of it over time. Really, if it is to be used only in the acute phases. So I think, you know, it's safe to say that it would affect outcomes. If we're using this type of visual vestibular integration approach or multisensory system approach, then the use of a suppressant would most likely affect outcomes. And so it's typically not recommended, obviously, to see the long-term use of vestibular suppressants. With your experience, do you think that every patient who suffers 3PD should take serotonin inhibitors? As a disclaimer, as a physical therapist, I do not recommend medications, but from like an educational standpoint, I will tell you in our experience, you know, we see SSRIs work great with some patients. We also have patients who completely refuse to take SSRIs. So, and so you're going to have a different perspective from the patients, and we want to meet the patients to, you know, learn what is their story, what are their goals, and be very cognizant about how a recommendation, how, you know, how that affects them. You'll have differences in providers. Like I know some ear, nose, and throat doctors, as well as neurologists, who treat this patient population, some want to start with cognitive behavioral therapy especially in the acute phases, and then try SSRIs, and then try vestibular rehab. I know someone else who likes to try vestibular rehab first. And, you know, there's other people who like to start with SSRIs. So there will be different approaches from different providers. So always come back to what is the patient's goal. I will say, however, I've definitely had patients who do well with cognitive behavioral therapy. They have plateaued somewhat with vestibular rehab, and there is maybe such a strong psychological component without the use of a kind of a deeper intervention, whether that's whatever that pharmaceutical intervention or therapy intervention may be. It is limiting their progress about what we can do. So we do find that with some patients, we think if they were open to using SSRIs, that they would have better outcomes, but they just simply do not want to take them. How does OPK work? That's a fantastic question. Decreased tolerance to optokinetic stimulation is thought to be a VOR maladaptation. I think that's the easiest way that I can describe it. So it is a mismatch. And what we know is that exposure to a large visual field can drive the VOR. So when you think about Dr. Day and his colleagues and their original proposal of the protocol for MdDS, what they wanted to do was provide the optokinetic stimulation to the patient, adding a passive head roll. And when I say roll, I'm just talking about head tilt, lateral head tilt. I'm going a little bit too big there. So at a slow oscillation that was just under the frequency related to motion sickness. And, you know, they ended up customizing that based on actual sway velocity. But in the beginning, and then some researchers have just a set velocity of that head tilt. Some researchers have the head still when exposed to up and down, or, you know, that's when the stripes are horizontal. And others will add a head movement to a standardized frequency when they're watching the stripes. So The reason we use the optokinetic is because it is related to the optokinetic reflex. And that has a significant driving force to the VOR. And again, this is overall thought to be a maladaptive VOR. And in doing just VOR exercises at faster rotations is most likely not enough. So that's the background of adding optokinetic stimulation or the exposure to stripes in this patient population. Okay, this is a great one. Not so much a question, it's just interesting, I think, based on the research. I'm a sailor. I work a lot with people in the sailing community. I'd love to hear more on the management, as well as tips for managing motion sickness or potentially preventing it. You know, most of the research that we see is recommending Klonopin, recommending, you know, vestibular suppressants prior to going on a boat in those patients who have already been diagnosed with MdDS. There's also been the thought of beginning to gradually expose people to this prior to being exposed to it on a boat. So the oscillation frequency, which I would have to go back and look at the literature, I think it's like 0.2 to 0.3 hertz, is associated with the frequency or the oscillation that we internally have after being on a boat. So what happens, and that has to do with sensory reweighting. So that was the purpose of this, you know, head roll exposed to the optokinetic stimulation. So what would be interesting is if you wanted to try some of the proposed MdDS protocols to see how someone might tolerate it. That's a little bit easier when we think about like astronauts. I mean, most of what we do today on VOR and postural stability and vestibular rehab came from, you know, our advances in traveling to space, and that we could not only optimize our vestibular system, but retrain it after it had been in this non-gravitational state, which was really where we saw the growth of vestibular rehab. So it'd be certainly interesting to see if others are doing preventive like therapies. If so, you know, ideally, you know, sharing that information, or just, you know, trying it and trying some of these protocols. You know, I had mentioned that we came up with this protocol. You know, some of you that I've seen on today's call have participated in our advanced vestibular rehab course, or our CCVR course. And that is going to be part of our next launch in into August, beginning of September, of our V2 Fit toolbox, where I'm going to share the optokinetic, I'm really hesitant to say protocol, but it is a protocol. And it's not because I know it works. It's because I wanted to standardize something, see how our patients respond, see how the clinicians can come together. But how amazing would it be if others out there tried it and said, you know what, I'm not finding this works. You know, I found that having them rest longer, I found that a day between, the research out there is so limited. And the research we have, I think it will continue to grow, but the need here is not only expanding our research, but how can we take the research and apply it? Because if you go take that deep dive into the literature right now, particularly about MdDS, it's not very practical in the clinic, where they have to come 5 days, they have to be there for a long time, and even some of the equipment. Now, there have been some more recent studies that indicate that it doesn't have to be full visual field. It needs to take up a certain percentage of our visual field. So we do have patients, we don't give exercises, OPK stimulation on their phone. We don't give them on the tablet, but it has to be a certain amount of taking up their visual field as we ask them to do those exercises in the clinic and also at home. Okay, well, we have a few minutes. We have a few minutes here. If anyone would like to share their thoughts or ask more questions. Okay, we have a question here. Could you please give suggestions where to start with how to use to progress a patient who is nearly a year post-concussion, who has got to the point she can manage the supernarc for 10 minutes? So not being able to be in the car, that is a little tricky because you've seen this improvement going out into a busy place, but this motion sickness of being in the car. We've tried a lot of different things about being in the car. We've put strobe glasses on patients. We typically start with them touching the car, optimizing somatosensory input. Most people would rather drive because they're in control. They know where they're going. They're getting feedback from the hands on the wheel. They know where they're going to look. Now suddenly they lose some of that control and they don't know necessarily what's going to happen. And they've lost the somatosensory input of the wheel and controlling it. So we ask them to put their arm on the car, feet on the ground. Oftentimes we ask them actually to focus on something. Now, that is usually to increase their tolerance. We don't like to do that for too long because this is motion sickness, not fully understood, most likely a visual vestibular mismatch. So let's teach them to feed into somatosensory, but ultimately working on this central to peripheral integration where they can tolerate stimulation outside their central visual field. So exercises typically then start to where we use optokinetic stimulation, but not just facing them. We use it in their periphery. So they may look forward and they don't have anything to focus on an unsteady surface, but the optokinetic straps are in their periphery because that's what's bothering them. So we use nasal occlusion on central peripheral integration. We have them, we do put them, if you have access to like the computerized dynamic posturography, it has a visual field where we can block the central visual field and then either have lines come at them, away from them, across in front of them. And so using different types of visual stimulation. And just baby steps. I see 5 minutes and I have to think baby steps. So where can we get this person, to be like, but I tolerated 7 minutes, but I tolerated 10 minutes, and gradually increasing the tolerance to that. It's sometimes we're thinking, well, I just can't be in a car. So, but could you be in a car for 5 minutes? So let's just be in a car for 7. If it's 5 minutes, then let's be in the car for 7 minutes. I mean, that does require someone to be actively engaged in helping such a slow progressive stimulation with the patient. Working in the community, nothing available. I always have to think there's always something available. So, out working in the community, I think if we think about these patients, our goal is to help improve their quality of life. And when we watch behaviors, oftentimes we see such an over-reliance on central visual cues. Either they're looking down at the ground or they're staring at an object, when life is about integrating central to peripheral visual cues. And the more we can help them with that process, so even if you think about VOR, and if you have someone that needs VOR, what are they doing? They're looking in the center and they're moving their head. Think about VOR out in the periphery. We don't like to spend a lot of time in the center. We like to either be in the periphery or crossing midline. So just think about those functional activities that you can do. Yeah, exactly. I do not believe you need computerized stuff. You know, we have in our clinic, yes, we have a CDP, we have a big TV that has Optokinetic straps, and we also have the science cardboard things where we have the material of black and white boxes stapled onto it that we set on top of a table and do exercises in. So whether, you know, we always need to be in a place where we don't have to rely on technology to implement something that can help our patients. What percentage of visual field is needed for optimal optokinetic training? Gosh, super great question, Valerie. What do you recommend for screen size, distance from screen to home training, laptop okay, new computer, TV screen? Really, the most of this research was done in an open, what I would call not virtual reality, was Dr. Pavlu and colleagues, and it seems like it's agreed that full field, like what if I could go into an entire room? Okay, that would be ideal, but that's not practical. Okay, now I can get in a dome, which is, I'm fully immersed in like the CDP, that's optimal. But there's also benefits from watching optokinetic stimulation on a desktop screen. So is full field all around better? Most likely, but it's questionable whether that's a clinically significant difference from just a large screen. It is recommended that tablets and smaller laptops, like I have a laptop over here and I don't even do a laptop. I want it to be 45 degrees up, down, side to side. And there was a study done in virtual reality, limited exposure in virtual reality goggles. And I believe that was 45 degrees in all directions, which showed benefits. Now, was the end of the study that we need to look at this more? Yes. But I think that we're going to see some promising things happen with virtual reality. But then we have to think about what happens when someone can't see their hands, and what happens, you know, if we're trying to feed into the somatosensory system. But don't forget, you can do this in sitting. So if someone is sitting, now if a patient has dizziness just in sitting and putting goggles on, they may not be ready for that. Some studies have recommended exposure to optokinetic stimulation outside of virtual reality goggles will help increase their tolerance to virtual reality goggles. So we have a lot to learn here. My recommendations are standardize what you're doing, try it, see if it works. You know, I've just adapted the SSQ. I'm so into acronyms, which is it's a questionnaire about motion sensitivity instead of the dizziness handicap inventory in this patient population. And it doesn't have a score, so we scored it. We added points to yes, no, sometimes. Or I mean, there's more options than that. And so we have them do it before the session, before they do their exercises. And then at the end, we don't have them redo it, but we just do a visual analog scale. And then the next time they go home and do it, we want them to do the questionnaire, and we modify it based on that. We modify it based on the facutas. So or if they say, you know what, I felt like I was being pulled to the left, now I'm being pulled to the right. So we ask them to switch. And so we have standard protocols. I want you to do it this long, this many times on day one. The next time I want you to do it this much on day, you know, this day I want you to add, if it's indicated, I want you to add stripes going up and down. I want you to rest this many times. And then, you know, let me know how you're doing. And so we're just giving them very clear, precise instructions. And it looks like I missed a question about vision therapy. So I'm going to scroll up a little bit. Do you ever refer to vision therapy? Yeah, we do. Absolutely. There's several neuro-optometrists in town, and there's a vestibular therapist who's actually in our advanced course. She's on our faculty, Natasha Johnson, and she is board certified by NORA and a vestibular therapist. And so if we feel there's a significant visual component to this, we'll, you know, when we can, we refer to her. So we definitely do. particularly if we think there is a visual impairment that needs to be addressed. Maybe prisms need to be prescribed before we start our rehab. And manual therapy. I mean, I think it's hard. I think it's impossible to separate the visual system, the inner ear, and the neck. And so we're looking at all of those components. Okay, I want to thank you so much for your participation. I will be recording this, or it is being recorded, and we will be making this available to you. So you can keep your questions coming. If you didn't feel like sharing anything today or asking anything today, please do so anytime. We are in this together. We're going to learn from each other. And I really appreciate you taking the time today to be a part of this. And we'll talk to you real soon.